The ichthyoses represent a heterogeneous group of genetic disorders characterized by abnormal epidermal differentiation and desquamation. Understanding the molecular basis of these conditions explains their diverse presentations and guides management strategies that can be life-saving in severe cases. The term ichthyosis derives from the Greek word for fish, reflecting the characteristic scaling pattern these conditions produce. The pathophysiology centers on disrupted keratinocyte differentiation and impaired desquamation, leading to accumulation of hyperkeratotic scale. Different genetic mutations affect various components of the skin barrier, from structural proteins like filaggrin to enzymes controlling lipid metabolism. This molecular heterogeneity explains why ichthyoses range from mild scaling disorders to life-threatening conditions. Neonatal presentations demand immediate recognition as they often require intensive supportive care. Collodion baby represents a phenotypic presentation rather than a specific diagnosis. These infants emerge encased in a tight, shiny membrane resembling plastic wrap. This membrane results from massive hyperkeratosis present at birth. As the membrane cracks and peels over 2 to 4 weeks, the underlying ichthyosis type becomes apparent. Approximately 85 to 90% develop either lamellar ichthyosis or congenital ichthyosiform erythroderma, though several other ichthyoses may present this way. Harlequin Ichthyosis represents the most severe end of the spectrum. Mutations in ABCA12 encoding a lipid transporter critical for lamellar body formation create profound barrier dysfunction. The resulting hyperkeratosis forms thick, diamond-shaped plates separated by deep fissures. This armor-like encasement restricts movement, breathing, and feeding, while creating massive portals for infection and fluid loss. X-linked ichthyosis, caused by steroid sulfatase deficiency, presents differently. Rather than dramatic neonatal manifestations, affected males typically develop dark, adherent scales during infancy. The enzyme deficiency prevents normal cholesterol sulfate breakdown, disrupting the desquamation process. Recognition matters because these patients may have associated testicular maldescent and corneal opacities, requiring additional evaluation. The critical concept linking all severe ichthyoses, infection, represents the leading cause of mortality. The disrupted barrier function creates multiple entry points for pathogens, while impaired immunity from malnutrition and metabolic stress reduces defense capabilities. Temperature instability and massive transepidermal fluid losses compound these risks. This understanding drives the intensive supportive care these infants require for survival. The Collodion baby presentation creates one of the most dramatic appearances in neonatology, requiring immediate recognition and systematic management to prevent life-threatening complications. Understanding the pathophysiology guides supportive care during the critical early weeks. The collodion membrane consists of markedly thickened stratum corneum forming in utero. This hyperkeratotic layer, unable to accommodate normal flexion and growth, creates the characteristic taut, shiny appearance resembling cellophane. As the infant moves and grows, the inflexible membrane develops fissures, particularly at flexural sites, allowing increased mobility while creating portals for infection and fluid loss. Respiratory complications arise through mechanical restriction. The tight membrane limits chest wall expansion, potentially causing respiratory insufficiency, while nasal and oral involvement may compromise airway patency. The ectropion and eclabium, eversion of eyelids and lips, result from membrane contracture, increasing corneal exposure and feeding difficulties, requiring protective eye lubrication and specialized feeding techniques. Temperature regulation becomes critically impaired through multiple mechanisms. The thickened, cracked membrane cannot provide normal barrier function, leading to excessive evaporative heat loss. Impaired sweating from eccrine duct obstruction prevents normal thermal regulation. These infants require precise environmental control in humidified incubators with temperature monitoring. Fluid and electrolyte management presents ongoing challenges, as transepidermal water losses may exceed 10 times normal rates. The membrane gradually sheds over 2 to 4 weeks, revealing the underlying ichthyosis phenotype. This process shouldn't be accelerated through mechanical debridement, which increases infection risk. Management focuses on maintaining skin integrity while supporting natural shedding. Petroleum-based emollients provide barrier support without systemic absorption risks. Keratolytic agents are prohibited during the neonatal period due to enhanced percutaneous absorption through compromised skin, risking salicylate toxicity. Long-term prognosis depends on the underlying ichthyosis type revealed after membrane shedding. Genetic testing during the acute phase helps predict outcomes and guide family counseling. Most collodion babies develop either lamellar ichthyosis or congenital ichthyosiform erythroderma, both requiring lifelong management but compatible with normal lifespan when appropriately treated. Initial presentation severity doesn't correlate with ultimate disease severity, making premature prognostication inappropriate. Harlequin ichthyosis represents the most severe genodermatosis compatible with life, though survival depends entirely on intensive modern neonatal care. Understanding the pathophysiology explains both the dramatic presentation and comprehensive support required. The molecular basis involves mutations in ABCA12, encoding an ATP-binding cassette transporter crucial for lipid transport into lamellar bodies. Without functional ABCA12, lamellar bodies cannot deliver essential lipids for barrier formation, creating catastrophic barrier failure. The stratum corneum lacks intercellular lipid lamellae, causing massive hyperkeratosis as compensation. The resulting armor-like plates, separated by deep, bleeding fissures, create the characteristic Harlequin pattern. Clinical features directly reflect this barrier catastrophe. Severe ectropion exposes the entire conjunctiva, risking corneal ulceration and blindness without aggressive lubrication. Eclabium creates a fixed, open mouth, compromising feeding and increasing aspiration risk. The thick plates restrict all movement. These infants cannot close their eyes, move limbs freely, or expand their chest adequately for breathing. Constriction bands around digits may cause autoamputation without intervention. Life-threatening complications arise immediately. Respiratory failure results from restricted chest expansion and airway obstruction. The massive fissure surface area creates portals for overwhelming sepsis. Hypernatremic dehydration develops rapidly from excessive fluid losses. Temperature regulation becomes impossible despite maximum environmental support. Feeding requires gastric tube placement as rigid eclabium prevents normal sucking. Without intensive support, mortality approaches 100% within days. Modern management has transformed outcomes through systematic intensive care combined with systemic retinoids. Oral isotretinoin or acitretin accelerate normalization of keratinization by modulating gene expression to partially compensate for the barrier defect. Treatment must begin within the first days of life for optimal effect. Supportive care addresses each system systematically. Pain management requires continuous attention, given severe pain from fissures and contractures. Prophylactic antibiotics may be necessary, given high infection risk. Nutritional support often requires parenteral supplementation to meet massive metabolic demands. Ophthalmologic protection prevents permanent vision loss. Survival beyond the neonatal period now occurs regularly with appropriate care. While patients require lifelong retinoid therapy and intensive skin care, many achieve independent function and good quality of life. Early physical therapy prevents contractures, while psychological support helps families adapt. Genetic counseling becomes essential given the 25% recurrence risk for this autosomal recessive condition. Epidermolysis bullosa encompasses rare genetic disorders sharing one devastating feature: skin blisters and erodes with minimal mechanical trauma. Classification matters profoundly because different genetic mutations affect specific structural proteins at various levels of the dermal-epidermal junction. The pathophysiology centers on defective proteins that normally anchor skin layers together. In epidermolysis bullosa, specific molecular components are missing or defective, causing separation at predictable levels. The classification system reflects which level fails, directly impacting prognosis and management approaches. EB simplex affects proteins within the epidermis itself, specifically keratins 5 and 14 in basal keratinocytes. When these intermediate filaments malfunction, basal cells fall apart under mechanical stress. Since the split occurs superficially within the epidermis, Healing typically occurs without scarring. This represents the mildest form, though infants still develop painful blisters from routine handling. Junctional EB involves mutations in proteins forming the basement membrane zone, laminin 332, type 27 collagen, or integrin subunits. These proteins create the crucial connection between epidermis and dermis. Their absence causes separation at the lamina lucida level. Many subtypes prove lethal within the first year due to extensive blistering, failure to thrive, and overwhelming infection. The basement membrane's critical role in multiple organs explains concurrent respiratory and gastrointestinal involvement. Dystrophic EB results from type 7 collagen mutations, affecting anchoring fibrils that secure the basement membrane to dermis. The deeper separation level explains why patients develop significant scarring. Healing involves dermal repair mechanisms that produce fibrosis. Progressive scarring leads to pseudosyndactyly, where digits become encased in scar tissue, and esophageal strictures from repeated mucosal injury. The crucial clinical challenge is that all types appear identical in newborns, blisters and erosions with minimal trauma. Visual inspection cannot differentiate between a child with EB simplex who will live relatively normally and one with severe junctional EB facing potential mortality. This diagnostic uncertainty creates profound stress for families awaiting definitive diagnosis. Diagnosis requires sophisticated techniques unavailable at most centers. Immunofluorescence mapping uses antibodies against specific structural proteins to identify which are absent or reduced. Electron microscopy visualizes the exact separation level. Genetic testing provides definitive diagnosis and enables prenatal testing for future pregnancies. These specialized biopsies require careful handling by experienced personnel, as improper technique can damage fragile tissue and compromise results. Managing epidermolysis bullosa in the neonatal period requires rethinking every aspect of routine care, as standard practices can cause devastating injury to these fragile patients. The overarching principle, prevention surpasses treatment, guides every clinical decision. The presentation varies from obvious extensive blistering at birth to subtle erosions developing over days. The pathognomonic positive Nikolsky sign demonstrates how lateral pressure causes epidermis to slip away from underlying tissue when mechanical trauma exceeds weakened adhesion forces. Common sites include areas of routine handling, heels from blood draws, back from positioning, perioral region from feeding. Infection represents the leading cause of mortality. Each blister creates a bacterial entry portal while healing's metabolic demands compromise nutritional status and immunity. The extensive surface area often exceeds that in burn patients, yet these infants lack robust inflammatory responses. Staphylococcus aureus and Pseudomonas aeruginosa pose particular threats. Preventing new blisters requires complete revision of handling techniques. Traditional swaddling creates dangerous friction. Instead, infants rest on soft padding without tight wrapping. Lifting requires supporting entire body weight from below, never grasping limbs or torso. Medical adhesives are absolutely contraindicated, as removal takes healthy skin. Blood pressure cuffs, ECG leads, and identification bands require modification or elimination. Wound care follows counterintuitive principles. Non-adherent dressings, like silicone-based products, prevent further trauma during changes. Blisters should be drained with sterile technique to prevent extension, but the roof remains as biological dressing. Topical antibiotics require careful selection. Many contain sensitizers, complicating fragile skin. The multidisciplinary approach reflects systemic impact. Dermatology guides skincare and diagnosis. Plastic surgery may release contractures. Nutritionists address increased caloric requirements. These infants may need 150% of standard intake. Pain management specialists balance comfort with safety. Occupational therapists teach parents trauma-minimizing handling techniques. Long-term planning begins immediately, as parents must become expert caregivers before discharge. Psychological support needs are profound. Parents grieve normal infant care loss while learning complex medical management. Connecting families with EB support organizations provides practical advice and emotional support from those understanding this journey. Subcutaneous fat necrosis represents a deceptively benign condition that can trigger life-threatening hypercalcemia. Understanding the pathophysiology explains why certain infants develop this condition and why vigilant calcium monitoring remains essential. The pathogenesis begins with injury to subcutaneous adipose tissue in newborns whose fat contains higher concentrations of saturated fatty acids that solidify at cooler temperatures. When exposed to cold stress or hypoperfusion, these fats crystallize, triggering granulomatous inflammation. The firm nodules represent areas where fat necrosis has induced inflammation and calcification. Risk factors share the common thread of tissue hypoperfusion or cold exposure. Birth trauma from forceps or vacuum extraction causes direct injury and ischemia. Therapeutic hypothermia for hypoxic ischemic encephalopathy may precipitate fat necrosis. Perinatal asphyxia creates systemic hypoperfusion affecting subcutaneous tissue. Maternal cocaine use causes placental vasoconstriction and fetal hypoperfusion. Red-purple, rock-hard nodules develop over areas with prominent fat: back, buttocks, thighs, and arms. The overlying skin may appear normal or show violaceous discoloration. These lesions typically manifest within 2 weeks of life. The firm, non-pitting nature distinguishes fat necrosis from infection or edema. The critical complication, hypercalcemia, develops as activated macrophages produce excess 1.2-dihydroxyvitamin D. This dramatically increases intestinal calcium absorption while mobilizing calcium from healing sites. Serum calcium may reach dangerous heights, causing lethargy, poor feeding, vomiting, seizures, arrhythmias, or renal failure. Hypercalcemia's insidious nature demands systematic monitoring. Elevations may not manifest until weeks after skin lesions appear and can persist 6 months. Weekly calcium monitoring for 1 month, then monthly for 6 months, catches most cases before symptoms develop. Management follows stepwise approach. Mild elevations respond to low calcium formula and increased hydration. Moderate hypercalcemia requires loop diuretics to enhance renal excretion. Severe cases demand aggressive intervention with IV hydration, bisphosphonates, or corticosteroids to suppress granulomatous vitamin D production. The differential includes scleroderma neonatorum, diffuse skin hardening in severely ill neonates with high mortality, unlike localized fat necrosis nodules that resolve completely in healthy infants. Birth trauma creates a spectrum of hemorrhagic lesions that require careful evaluation to distinguish benign findings from potential bleeding disorders. Understanding the mechanical forces during delivery explains both the pattern of these lesions and when additional workup becomes necessary. Petechiae, those pinpoint hemorrhages resulting from capillary rupture, commonly occur on the presenting part during delivery. The pathophysiology involves increased intravascular pressure during passage through the birth canal, overwhelming capillary integrity. When the fetal head compresses against maternal pelvic structures, venous return becomes impaired while arterial pressure continues, creating the pressure gradient that ruptures small vessels. Nuchal cord compounds this effect by impeding jugular venous drainage, explaining why facial petechiae often accompany tight nuchal cords. Vacuum and forceps deliveries amplify these forces through direct mechanical trauma and negative pressure effects. The distribution pattern provides crucial diagnostic information. Petechiae limited to the presenting part, typically the face and scalp in vertex presentations, represent mechanical trauma rather than coagulopathy. This localized pattern, above an imaginary line at the nipples, reflects the pressure differential experienced during delivery. However, petechiae extending below this demarcation or appearing in non-traumatized areas suggest systemic etiology requiring investigation. The temporal pattern also matters. Traumatic petechiae appear immediately at birth and don't progress, while coagulopathy-related lesions may evolve over hours to days. Ecchymoses represent deeper, more extensive hemorrhage from greater vascular disruption. Forceps create characteristic linear or curved bruises corresponding to blade placement, while vacuum extraction produces circular ecchymoses at the application site. The pathophysiology extends beyond simple vessel rupture. Shearing forces separate tissue planes, allowing blood to dissect through subcutaneous tissues. This explains why ecchymoses may extend beyond the initial trauma site over the first 24 to 48 hours. The clinical significance of birth-related hemorrhage extends beyond cosmetic concerns. Blood breakdown from extensive bruising contributes substantially to neonatal hyperbilirubinemia. Each gram of hemoglobin yields 35 milligrams of bilirubin, overwhelming the immature conjugation system. Infants with significant bruising require enhanced bilirubin monitoring and lower thresholds for phototherapy initiation. The documentation importance cannot be overstated. Detailed descriptions, measurements, and photographs protect against future abuse allegations while establishing traumatic etiology. Parents need education about expected color evolution from purple to green to yellow as hemoglobin degrades, preventing unnecessary concern as lesions change appearance. Staphylococcal skin infections in neonates range from localized, superficial infections to life-threatening systemic disease. Understanding how different strains and toxins interact with neonatal skin guides diagnosis and management. Bullous impetigo represents the most common staphylococcal skin infection, caused by phage group 2 Staphylococcus aureus, producing exfoliative toxins A and B. These toxins target desmoglein 1, a crucial adhesion molecule in superficial epidermis. The resulting loss of cell-to-cell adhesion creates intraepidermal cleavage, forming characteristic flaccid bully. The superficial split explains why lesions rupture easily, leaving honey-colored crusts. The localized nature reflects toxin production at infection sites without systemic absorption. Management depends on infection extent and infant age. Limited lesions in well-appearing infants may respond to topical mupirocin, though thin neonatal skin enhances systemic absorption. More extensive involvement requires systemic antibiotics, typically first-generation cephalosporins or anti-staphylococcal penicillins. Rising MRSA prevalence complicates empiric therapy choices. Staphylococcal scalded skin syndrome represents the severe spectrum, where exfoliative toxins reach systemic circulation. Pathophysiology involves toxin production at distant foci, often conjunctivitis, omphalitis, or occult abscess, with hematogenous spread. Circulating toxins create widespread desmoglein 1 cleavage, causing diffuse erythema, followed by superficial desquamation. The positive Nikolsky sign demonstrates widespread epidermal fragility. The toxin-mediated nature creates important clinical distinctions. Cultures from denuded skin remain sterile, since damage results from circulating toxins rather than direct invasion. This explains why topical antibiotics provide no benefit. Systemic therapy targeting the primary source is essential. The superficial separation level allows rapid re-epithelialization without scarring. Once toxin production ceases, supportive care mirrors burn management while antibiotics eliminate the toxin source. Differential diagnosis requires careful attention. Epidermolysis bullosa shows trauma-related blistering from birth, while SSSS develops in previously normal skin. Drug reactions typically include mucosal involvement, which SSSS spares, since mucous membranes lack desmoglein 1. Stevens-Johnson syndrome creates full-thickness necrosis with hemorrhagic crusts, contrasting with SSSS's superficial, non-hemorrhagic separation. Congenital infections often announce their presence through distinctive skin findings that provide crucial diagnostic clues. Understanding the pathophysiology enables rapid recognition and appropriate evaluation of potentially devastating systemic infections. The blueberry muffin rash represents one of the most striking manifestations, resulting from dermal extramedullary hematopoiesis. During fetal development, severe infections overwhelm normal hematopoietic capacity, triggering blood cell production in extramedullary sites, including skin. These hematopoietic cell collections create purple-blue papules and nodules resembling blueberries scattered across the skin. Cytomegalovirus, rubella, and parvovirus B19 most commonly cause this phenomenon. These lesions feel firm and non-blanching because they represent cellular infiltrates rather than hemorrhage. The blue coloration results from optical properties of deep dermal blood cell collections, viewed through overlying skin. Distribution favors the head, trunk, and proximal extremities, where fetal hematopoiesis is most active. Unlike petechiae, these lesions persist for weeks as ectopic hematopoietic tissue involutes. Congenital syphilis produces pathognomonic palmar and plantar findings. The copper-colored maculopapular eruption results from spirochete invasion of dermal vessels, creating vasculitis-like reaction. The predilection for palms and soles reflects high vessel density, providing abundant targets for treponemal infection. This distribution is virtually diagnostic. Few neonatal conditions preferentially affect these sites. Herpes simplex virus creates varied cutaneous manifestations. Classic group vesicles on erythematous base reflect viral replication in keratinocytes, causing cellular ballooning and intraepidermal vesicle formation. However, neonatal HSV often presents atypically. Disseminated disease may produce widespread vesicles lacking typical grouping. Some infants present with isolated mucosal lesions. Up to 40% of neonatal HSV cases lack cutaneous findings at presentation. Evaluation must balance thoroughness with urgency. PCR technology enables rapid, sensitive detection from vesicle fluid, blood, and cerebrospinal fluid. For suspected HSV, empiric acyclovir should begin while awaiting confirmation, as early treatment dramatically improves outcomes. Syphilis requires both treponemal and non-treponemal testing. Long-term monitoring depends on the pathogen. CMV-infected infants need audiologic and developmental surveillance. Congenital rubella requires multi-system evaluation. The skin manifestations enable early diagnosis often resolve, but recognition allows timely intervention, preventing permanent sequelae. Nutritional deficiencies manifest prominently through skin changes in neonates, where rapid growth and limited reserves make these infants particularly vulnerable. Essential fatty acid deficiency increasingly complicates care for infants dependent on total parenteral nutrition. Without linoleic and alpha-linolenic acids, the skin cannot produce normal barrier lipids. The stratum corneum develops abnormal structures, causing increased water loss and characteristic scaling. This typically appears after 2 to 4 weeks without lipid supplementation, though premature infants may develop symptoms sooner. Diagnosis relies on an elevated triene to tetraene ratio above 0.4. When linoleic acid is absent, the body produces mead acid as a substitute, creating this abnormal ratio. Clinical findings include generalized scaling, poor wound healing, and increased infections. Perioral and intertriginous areas show the most pronounced changes. Management requires lipid supplementation through intravenous emulsions or enteral feeds. Modern formulations providing 20 to 30% of calories as lipids prevent deficiency. Response occurs rapidly, biochemical improvement within days, clinical resolution within 2 weeks. Acrodermatitis enteropathica results from impaired zinc absorption. Zinc serves as a cofactor for over 300 enzymes crucial for epithelial function. Deficiency creates characteristic periorificial and acral dermatitis, erythematous, scaly plaques around mouth, nose, eyes, and anogenital regions. Hands and feet develop similar lesions with paronychia. This Bridges pattern should trigger immediate zinc evaluation. Zinc supplementation at 2 to 3 milligrams per kilogram daily produces dramatic improvement within days. Inherited forms require lifelong treatment, while acquired deficiency resolves with adequate nutrition. Biotinidase deficiency prevents biotin recycling, disrupting multiple metabolic pathways. Manifestations include alopecia, starting with eyebrows and lashes, plus eczematous dermatitis. Unlike benign seborrheic dermatitis, untreated biotinidase deficiency causes progressive neurologic damage, making early recognition critical. Developmental anomalies visible at birth often represent embryologic remnants or morphogenesis errors. Understanding their basis helps predict associations and guide management. Auricular tags arise from accessory hillocks of hebizon that persist during ear formation. These flesh-colored papules anterior to the ear may indicate disrupted first and second branchial arch development. Surgical excision by experienced surgeons is preferred over suture ligation, which risks incomplete removal, infection, and hemorrhage. Vascular supply often extends deeper than expected, and facial nerve branches may course nearby. Optimal timing balances cosmetic concerns with anesthetic safety, typically between 6 months and 1 year. The hearing loss association remains controversial. Isolated tags may not require audiologic screening beyond standard protocols, though additional anomalies warrant evaluation. Supernumerary nipples follow embryologic milk lines from axilla to groin. These memory ridge remnants appear as pigmented macules that may respond to hormonal stimulation. Recognition prevents unnecessary concern. Preauricular pits represent epithelial folding errors, creating small openings with variable tract depth. While usually asymptomatic, infection can create chronic drainage. The branching nature makes complete excision challenging once infected. Midline anomalies require careful evaluation for neural connections. Hair collars particularly suggest heterotopic brain tissue. Any midline lesion from glabella to coccyx potentially communicates with the central nervous system. Sacral dimples within 2.5 centimeters of the anus rarely associate with spinal dysmorphism. However, higher dimples, or those with hair tufts, hemangiomas, or drainage, require imaging. Ultrasound adequately evaluates newborns, while older infants need MRI. Early detection enables intervention before neurologic damage. These findings remind us that external anomalies may indicate internal abnormalities. Understanding embryologic basis transforms observation into targeted evaluation.